So we're starting, guys. Welcome to today's CME. My name is Lena, and I'll be moderating. So a brief intro on XYZ Med. It's a vibrant community of Kenyan medical students from various universities dedicated to transforming medical education in Kenya. The initiative aims to create accessible, locally relevant and context-specific resources that address the unique healthcare challenges faced in the region. Kenya's current medical education system heavily relies on foreign resources, which are often not entirely applicable to the local healthcare landscape. The mismatch results in gaps in both education and preparedness among healthcare professionals, while also contributing to limited public awareness about various medical conditions, further complicating healthcare delivery in the country. To bridge these gaps, XYZ is developing a variety of educational resources, including relatable medical illustrations, case simulations, lectures, quizzes, healthcare stories, research, and interactive learning tools. This CME series is one of our key initiatives aimed at promoting peer-to-peer learning among medical students. We recognize that it's often easier to understand complex medical concepts when explained by peers and classmates, which is why this series is designed to foster collaborative learning. Today's CME will focus on spondyloarthropathies, and we are pleased to invite our speaker of the day. And I'll introduce him. He is Owino John, an MBCHB5 student at UON, and he'll take us through this topic. I hope you have a good time and you learn as much as you can from it. So welcome, John. You're free to begin.
Thank you, Lena.
You're welcome.
Okay, so I'm John, as she said, and I'll take us through spondyloarthropathies. I hope you all can hear me. So I'll share my screen. Just a minute.
Okay, so as our speaker prepares, I'd like to tell you about our research. So there's a study about exploring tomorrow's contraceptive frontier, and it's a public perception study among the Kenyan youth towards new reversible vaso-occlusive male contraceptive methods in developments. So it'll just take 2 minutes, and a brief background. Vaso-occlusive contraceptive methods are a new type of male contraceptives currently being developed, and they show a lot of promise. So before participating in the study, I'd like you to to watch something. Just give me a minute to watch something. Let me see if I can share my screen. Or if I can, let me paste the link in the chat box to be a bit easier. Can you see my screen? I hope you can see my screen. I want to play you the video on the contraceptives.
This week is World Contraception Awareness Week, and XYZEZ Med Research Department would like to invite you to participate in our study titled Exploring Tomorrow's Contraceptive Frontier, a public perception study among the Kenyan youth towards new reversible vase-occlusive male contraceptive methods in development. This work is supported by the Male Contraceptive Initiative, which is an organization that supports advocacy and research on new male contraceptive methods. Did you know that in Kenya, 14% of women aged 15 to 49 have an unmet need for family planning, which leads to high rates of unintended pregnancies? The Kenya Demographic Health Survey estimates that 43% of pregnancies in the country are unwanted or mistimed. Family planning and contraceptive practices traditionally place the majority of the burden on women. However, evidence has shown that the neglect of men's role in sexual and reproductive health has greatly hindered efforts to increase contraceptive use in sub-Saharan Africa. Active male participation in family planning is paramount for comprehensive and effective family planning. One of the ways men can actively participate in family planning is through the use of contraceptives. One of the challenges in getting men to actively participate has been the limited options available for men, with effective methods being largely limited to condoms and vasectomy. In recent times, there have been several promising advances in male contraceptive research, among them being the use of injectable, reversible, non-hormonal male contraception. To explain how this new method works, the testes is an organ responsible for the production of sperms. These sperms are released into a tube known as the vas deferens that transports the mature sperm to the urethra in preparation for ejaculation. Vaso-occlusion is a new, minimally invasive, non-hormonal and reversible male contraceptive procedure that is in development and involves injection of an occlusive polymer into the vas deferens. The vaso-occlusive polymer occludes the lumen of the vas deferens and acts as a selective physical and physiological barrier to the passage of sperm, which leads to sterility. When reversal of sterility is desired, a reversal agent then dissolves and flushes out the occlusive polymer, making the person fertile again without any notable side effects. Vaso-occlusion offers significant advantages over vasectomy, primarily due to its reversibility, its non-invasive nature, and the lack of hormonal effects. Unlike vasectomy, which is typically permanent, vaso-occlusion is designed to be easily reversed through a second injection that dissolves or removes the polymer, blocking the vas deferens, restoring fertility. The procedure is also less invasive, involving only an injection rather than surgery, which minimizes recovery time, pain, and the risk of complications. Additionally, since vaso-occlusion is non-hormonal, it doesn't affect testosterone levels or sexual functions, avoiding the hormonal side effects some contraceptives may cause. With minimal or no scarring due to the lack of surgical cutting, vaso-occlusion presents a promising, flexible option for long-term male contraception. Promising technologies in this field include RESUG, Vasogel, and ADAM. RESUG has already undergone promising clinical trials in India. while Vasagil and Adam are in the trial phase in the United States and Australia respectively. The studies on reversal have only been completed on animal models as of now, where they have shown great promise. These methods promise to be effective for years with just a single injection, which could revolutionize the role of men in family planning by providing them with more control over their reproductive choices, while simultaneously reducing the contraceptive burden on women. The introduction of vaso-occlusive male contraceptive methods into the market could significantly alter global family planning dynamics, offering men reliable and reversible contraception methods. Their development aligns with the growing demand for male contraceptive options that are not only effective but also user-friendly and reversible, thus addressing the unmet needs in family planning and reducing the contraceptive burden on women. The purpose of this study is to investigate the awareness, attitudes, and beliefs of Kenyan youth, both men and women, between the ages of 18 to 35 years, regarding these reversible vaso-occlusive male contraceptive methods that are currently in development. We invite you to participate in this study and to share your opinions regarding this. Participation in this study is voluntary, and there's no known risks associated with participation in this study. No personal information will be collected for this study, and all information collected during the study will be kept strictly confidential. The link to participate in this study is attached to this video's description. In case of any queries, you can contact xyzzmed@gmail.com. Thank you.
XYZ, XYZ, XYZ.
Okay, so I'll paste the link in the chat box, and you're free to participate in the study. Let me paste it, and yes. Okay, so John, are we okay? Are we ready?
Yeah, we are set.
Okay, sawa.
All right, so I'll give us an overview of spondyloarthropathies. Some will refer them to as spondyloarthritis, while others will refer them to as spondyloarthritis. All those are one and the same. And we'll appreciate that the etymology of that word, spondyloarthropathies or arthritis, stem from three Greek words: spondylo to mean spine, arthro to mean joint, and pathy to mean pathology or disease. So spondyloarthropathy will be a joint disease of the spine. Okay, so we'll proceed to the next slide. That's our outline. Introduction, we'll go through classification, pathophysiology, diagnosis and treatment of these diseases. Okay, so spondyloarthritis or arthropathies are a group of inflammatory rheumatic diseases. And as we cover the groups of diseases, we'll appreciate that they are not necessarily, some are not necessarily involving the spine, but they share common characteristics. That is a chronic inflammatory conditions, enthesitis, and association to HLA-B27. So enthesitis in this case would mean inflammation of the points that the tendons attach to the bone. So that is enthesitis or enthecytopathy. Okay. Let's proceed. Okay. So these are the main types of spondyloarthropathies. So we have axial spondyloarthritis. It's a spectrum of axial spondyloarthritis, where we have non-radiographic spondylitis on one end and ankylosing spondylitis on the other end of the spectrum. Then we have psoriatic arthritis. So that is a joint inflammation associated with psoriasis. Then we have reactive arthritis. That's joint inflammation that occurs after infection. Then we have enteropathic arthritis that's associated with inflammatory bowel disease. So you have your joint involvement as extra-articular features of inflammatory bowel disease, that's Crohn and ulcerative colitis. Then we have juvenile spondyloarthritis. Basically, spondyloarthritis that begins before the age of 16, that is in childhood and adolescence. Then we have undifferentiated spondyloarthritis. Basically, joint involvement that resembles spondyloarthritis, but not sufficient to be categorized into either of the previously mentioned groups. Okay. So we'll start with the axial spondyloarthritis, and we'll appreciate that axial spondyloarthritis is a spectrum of spinal joint inflammation that can be mild to severe, can range from mild to severe. So for mild axial spondyloarthritis, we have non-radiographic features of sacroiliitis. So that means you can't see sacroiliitis on the plain X-ray, but when you do an MRI, you'd see features of sacroiliitis. That would be sclerosis of articular surfaces, or widening or narrowing of the joint gap. So other than non-radiographic spondyloarthritis, axial spondyloarthritis, we also have we'll have radiographic axial spondyloarthritis. So you'll see sacroiliitis on a plain X-ray. And then most of the severe forms of axial spondyloarthritis is this ankylosing spondylitis that's here. So that would be when you find a patient with fused joints of the spine, then that would mean it's a late form of the disease. And what you'll see on the chest, on the spine X-ray, would be syndesmophytes that have fused to form what we call a bamboo spine. So syndesmophytes are basically osteophytes that are formed by, they're formed due to periostitis, periosteal reaction with reactive bone formation. And then when they grow vertically and fuse, they form that syndesmophyte. And radiographically, you'll see a bamboo spine, as we'll appreciate in the subsequent slides. So the key features of ankylosing spondylitis are chronic back pain. Chronic to mean more than 3 months. So you have chronic back pain and stiffness. And we'll appreciate that this back pain is inflammatory to mean that it occurs with rest or early morning or even at night, but improves with motion. Okay, so we also have sacroiliitis. That's simply inflammation of the sacroiliac joints, and spinal fusion, that is the bamboo spine, as I had mentioned. Okay, so on physical exam, patients with ankylosing spondylitis will have a characteristic feature. So for Schober's test, you mark 2 points on the patient's back when they stand upright, 5 centimeters below the sacroiliac joint, lumbosacral joint, and 10 centimeters above it. And then you ask them to bend forwards. And ideally, that distance, so if you add 10 plus 15, 10 above the lumbosacral joint, plus 5 up below the lumbosacral joint, it's 15. So when they bend, that distance is supposed to increase by 5 centimeters or more if they're normal. But in an ankylosed spine, that distance won't increase as much as that. So it will be 4 centimeters or less. Okay, and that's how you'll detect or see that that's a problem. Okay, so that's how Schober's test is done. Okay, next you have psoriatic arthritis. And we know that psoriasis is a systemic condition. So it usually manifests as a skin condition, scaly lesions, especially on the extensor surfaces of the limbs. And articular involvement is usually asymmetric and oligoarthritis, especially when it's peripheral joints that are involved. So it's oligoarthritis if it's peripheral joint involvement. And we have psoriatic arthritis that also may involve the axial spine. And when you compare the X-ray for spinal X-ray for psoriatic and ankylosing spondylitis, you'll appreciate that the syndesmophytes in psoriatic arthritis are more conspicuous and asymmetric compared to a spine of an ankylosed, compared to an ankylosed spine. Yeah? Other than articular involvement, you also have nail changes. And some would say that the nail changes are usually an accompaniment of DIP arthritis, so that's distal interphalangeal joint arthritis or inflammation. So they are considered an extension of distal interphalangeal joint arthritis. So the nail changes are like pitting or onycholysis. You can also have hyperkeratosis or even discoloration of the nail. Okay. All right, so those are scaly lesions on the skin or plantar surfaces of the limbs, as you can see. So those are extra-articular manifestations of psoriatic arthritis. So those are the nail changes. So you can see hyperkeratosis, yellow discoloration of the nails, horizontal ridging, and onycholysis down there. Okay, so there's a spectrum of arthropathy in psoriatic arthritis. So you can have arthritis of the distal interphalangeal joints. You can have asymmetric oligoarthritis. Oligo to mean two to four joint involvement. We can also have symmetric polyarthritis that's similar to rheumatoid arthritis. But what will differentiate it from rheumatoid arthritis would be skin lesions in psoriatic arthritis. And also when you do a rheumatoid factor labs, you'll find rheumatoid factor negative in psoriatic arthritis. So that's symmetrical polyarthritis in psoriatic arthritis, how to differentiate it from rheumatoid arthritis rather. We can also have an axial involvement and arthritis mutilans. Arthritis mutilans is a severe form of psoriatic arthritis that involves highly deforming lesions. Okay. Okay, so that's dactylitis, involvement of the interphalangeal joints, and it happens, then it appears usually swollen because of involvement of both the joints and the joint cartilage as well as are inflamed, and that's why you'll have that sausage-shaped digit. Then for arthritis mutilans, you can see their distributions, and you can appreciate that those digits are psoriatic arthritis. Okay. Okay, we can move to the next slide. All right. Next, we have reactive arthritis, and this is inflammation of the joints, usually after an infection, and time that usually, or the time between the resolution of the infection to the onset of arthritic symptoms is usually about 4 to 6 weeks. And we can also appreciate extra articular features of reactive arthritis, such as conjunctivitis and urethritis. There was usually a term, I understand that it's obsolete right now, Reiter's syndrome, that comprises that triad of arthritis, conjunctivitis, and urethritis. So common triggers of reactive arthritis are uro or genitourinary infections such as chlamydia and enteric infections such as salmonella. So it happens after those infections have been resolved, but in other few circumstances, the offending pathogen can be isolated, especially in chlamydia infections. So you can have both an aseptic and aseptic, but for septic arthritis, they usually the minority of the cases. So reactive arthritis is usually mostly peripheral spondyloarthritis that is asymmetric and oligoarthritis, to mean it involves 2 to 4 joints. Okay, other considerations on reactive arthritis is involvement of HIV and COVID-19. So we'll appreciate that reactive arthritis it's usually associated now in our setting, in our African setting, it has been associated with HIV, same to psoriatic arthritis. So for our case, it's usually HLA-B 27 negative, and for the European population, it's usually HLA-B 27 positive. COVID-19 association with reactive arthritis poses a challenge in terms of treatment. We know that treatment of reactive arthritis is associated with flare-ups of COVID or worse, because mostly during the pandemic, and that's it. So another point to note this form of arthritis is usually and radial inflammatory to reduce tension and pain, while letting the natural course of the disease take place. So it resolves after 3 to 6 months, but in some cases, it can take up to even a year or so. Okay, that's it. Can proceed. All right. Next, you have enteropathic arthritis. Some will refer to it as inflammatory bowel disease related arthritis.
Hey, John. You're
Hello.
breaking a bit. If you could check your connection.
Okay. Am I audible right now? Okay, we can proceed. So it can co-occur with Crohn's or ulcerative colitis, or it can even proceed that inflammatory bowel disease. And it can be an axial spondyloarthritis or a peripheral. And when it's peripheral arthritis, then it's usually asymmetric oligoarthritis. Okay, so I've said the symptoms can parallel IBD, or they can predate IBD symptoms. Okay. All right. So this group of undifferentiated spondyloarthropathies are those that occur as symptoms of spondyloarthritis, but not sufficient to fit in a single category. So that's why they are undifferentiated spondyloarthritis. For example, when you have features of spondyloarthritis that are related to maybe something like you have extrarticular features like uveitis, and you don't have other defining features, for example, psoriasis or inflammatory bowel disease, then you will say that's undifferentiated spondyloarthritis. Okay. All right. So this is a table summarizing the key features of those spondyloarthritis. And we can see ankylosing spondylitis has a bamboo radiographic feature of bamboo spine with common symptoms such as low back pain and stiffness. Psoriatic arthritis has nail changes in addition to skin lesions. So common symptoms are joint pain and skin lesions. For reactive arthritis, the defining feature is that they usually occur post-infection. And you can have that triad of arthritis, conjunctivitis, and urethritis as Reiter syndrome. You can also have enteropathic arthritis that's associated with inflammatory bowel disease. And symptoms are basically joint pains that parallel inflammatory bowel disease. Okay. All right. So what's the pathophysiology of spondyloarthritis? So these are chronic inflammatory diseases that are thought, the exact cause is unknown, but they are thought to come about as a result of an interplay of genetic factors such as HLA-B27, with the predilection of HLA-B27, immune dysregulation, and environmental triggers. So for immune dysregulation, there are pathways such as the chemokines implicated are like tumor necrosis factor, interleukin 17 and 23. And that's why in their treatment, you will appreciate that for biologics, you have anti-TNF and anti-IL-17 and 23. Okay, so this is a bar graph showing interrelation of these the interrelation of these spondyloarthritis with HLA-B27, and we see that among them, ankylosing spondylitis is the most related to HLA-B27 positivity, followed by reactive arthritis. Okay, so HLA-B27 positivity can be used as a prognostic prognosticator for this disease. And we know that if the HLA-B27 is positive, then that's usually a poor prognostic indicator compared to a HLA-B27 negative result. Okay, so these are the overall clinical features of spondyloarthropathies. So you have inflammatory back pain, and I explained what inflammatory back pain is. So that's back pain that occurs mostly at rest, or in the morning, or in the evening, at night when someone is rested, but resolves with motion. You also have enthesitis. We said enthesis is a point in the bone where the tendons attach to. So enthesitis is inflammation of that point. We also have dactylitis, inflammation of the entire digits so that they become sausage shaped. And we said it's synovitis plus tenosynovitis. That's why the entire digit is involved. Also extra-articular symptoms such as uveitis, sometimes scleritis, inflammatory bowel disease, and psoriasis, or even urethritis in some cases of reactive arthritis. Yeah. Okay, so how do we diagnose? So diagnosis is by history, physical exam, and investigations. Yeah. So your history, you'll have back pain lasting more than 3 months in a fairly young individual. So if this back pain is it's in a person of an older age, let's say 60 years or above, and its onset is recent, then you can't, okay, spondyloarthritis, much as it will be among your differentials, it won't be the first one. It won't be among the first one. So this chronic back pain is usually in individuals who are younger, so 45 or less. Morning stiffness and pain that improves with exercise, but worsens with rest. Okay, we can proceed. All right. Other than history, you can do your physical exam. So physical exam, okay, that part is missing here. So physical exam, you can do for ankylosing spondylitis, you can do your Schauber's test. You can also look out for extra-articular features, such as uveitis or conjunctivitis, or urethritis, okay? Then you can do your investigations. So investigations will be divided into labs and imaging. So your imaging, you'll look for some radiologic features. So for a sagittal, so a sagittal X-ray of the spine, you will be able to appreciate a bamboo spine. And then you can also see a sacroiliitis in an anteroposterior X-ray of the pelvis. MRI is also useful in early detection of inflammation, especially in non-radiographic sacroiliitis. You remember we had a spectrum of axial spondyloarthritis that varied from mild, that is non-radiographic sacroiliitis, to severest form, that is ankylosing spondylitis. So we will not be able to appreciate these non-radiographic sacroiliitis in an X-ray, but there are subtle features that can be detected by an MRI. You can also have a CT that will indicate structural damage. We can proceed. All right, so for your labs, you have important markers. Now, labs are not really necessary to diagnose spondyloarthritis, but they can be useful to reinforce it or for prognostication, especially markers like HLA-B27. They'll be useful for your prognostication. You can also have inflammatory markers like CRP and ESR elevated. And to differentiate symmetric polyarthritis in spondyloarthritis from symmetric polyarthritis in rheumatoid arthritis, you can check for your rheumatoid factor, and you will appreciate that it's negative in spondyloarthritis while positive in rheumatoid. So that's the use of that rheumatoid factor. Okay. All right. So there's an ASAS classification criteria for axial spondyloarthritis. So you will have radiographic. Okay, I think these slides are not updated, so it's missing here. So we have clinical features. If you have a background of a chronic inflammation occurring for more than 3 months in an individual who is 45 years or less, then you want to see your radiographic features. If your sacroiliitis is evident on an X-ray or not, and then you will also couple your clinical features to secure a diagnosis for axial spondyloarthritis. So that's basically an overview of that ASAS classification criteria. So if you have a background of chronic inflammation or chronic back pain in an individual who is 45 or less, and then you see if you have radiographic features of sacroiliitis or not. So if you have radiographic features of sacroiliitis, that is sclerosis of the articular surfaces, or widening or narrowing of the joint gap, or even fusion, then you only need one extra-articular feature to secure your diagnosis of axial spondyloarthritis. And we know our extra-articular features are like uveitis, inflammatory bowel, psoriasis, urethritis, name them. On the other hand, if you have that similar background of chronic back pain in a person less than 45 without radiographic features, then you need 2 or more instead of 1. So you need 2 or more extra-articular features to secure your diagnosis of an axial spondyloarthritis. So that's it. You can proceed. All right. So for your treatment, your overall management goals would be to reduce inflammation, to maintain function and mobility, and to prevent progression of disease. So what are our treatment options? Next slide. Okay, next slide. All right. We have non-steroidal anti-inflammatory, synthetic disease-modifying DMARDs. We can also have biologics and corticosteroids. So NSAIDs are usually the first line of treatment choice in spondyloarthritis, and their function is to reduce inflammation and they're usually effective for mild to moderate spondyloarthritis. Okay, so when you have severe forms of spondyloarthritis, then your NSAIDs like brufen and naloxone won't work, won't suffice. You will opt for conventional synthetic disease-modifying anti-rheumatic drugs, yeah? Like sulfasalazine, methotrexate, you name them. So a point to note is that for NSAIDs, their dosages are usually high compared to regular dosages. And what you'll do, you need to cover them with PPIs to prevent the peptic ulcer disease. Okay, so for synthetic DMARDs, we say that they are for moderate to severe forms of spondyloarthritis. And we have drugs like sulfasalazine and methotrexate. We know that they're useful for spondyloarthritis like psoriasis, psoriatic arthritis, and axial spondyloarthritis. They are not useful for reactive arthritis because we said the reactive arthritis is mostly self-limiting, and they'll be sufficiently covered by NSAIDs. Then you also have biologics. Biologics like tumor necrosis factor alpha inhibitor and interleukin 7, anti-interleukin 17. So biologics are for moderate to severe cases of spondyloarthritis, and their use is usually associated with dramatic resolution of the symptoms. Yeah, and the disease progression is usually arrested. Okay. Then we have corticosteroids. So for corticosteroids, they only useful for peripheral. Okay, they're mostly used for peripheral asymmetric oligoarthritis, where you have intralesional injections to prevent systemic effects of steroids. But for symmetric polyarthritis and extraarticular symptoms, you can also have low-dose systemic steroids, and we are careful to taper them off. They're clinically useful to bridge the gap between the onset of action of these DMARDs, yeah, or even biologics. So they're because the DMARDs usually take a while to start to, therefore their functions or their effects to be appreciated, you use low-dose systemic steroids to cover that time. But by the time the DMARDs start working, you're supposed to be tapering off your steroids. All right. So most preferably intralesional steroids. So that's intraarticular. But if they're systemic, you use low-dose steroids. Okay. So that's it. Do you have any other slide? Okay, that's it. All right. Any question?
Thank you very much, John. It was a very good session, a very good talk. So now we'll go into the Q&A session, the Kahoot session. So in the chat, there's a link, the kahoot.it. I'll share the code in a minute. Let me share my screen. You can, in the meantime, let's log into kahoot.it. Can you see my screen?
Yes.
Okay. Oh, just a minute. Let me stop sharing so I can log in. Just give me a minute. I hope you can see the screen. So the game pin is 9798433. I'll give you a minute so you can join. I'll start in a minute. Okay, let's start. Okay, the answer is bamboo spine. Next. So we have AS leading followed by DCI. Let's continue. Okay, the answer is ankylosing spondylitis. And that's the scoreboard. Let's go on. HLA-B27. AS still leading, followed by robot, I guess. Next. Okay, reactive arthritis. Okay, good job, pancake. Okay, we have TNF inhibitors next. Okay, so butterfly rash is not a common extraarticular feature. Still leading AS and has a streak of 6, followed by robot. Let's keep going. Okay. So enteropathic arthritis can involve peripheral joints and the spine, and that's exoid involvement. Okay, good job, Ian. Let's keep going. Okay, psoriatic arthritis. Ian is leading, followed by AS. Let's keep going. Okay, MRI. Mhm. Okay, so they would develop kyphosis. AS followed by robot and pancake with the wind streak. On to the last question. We have both ulcerative colitis and Crohn's disease. So thank you for participating. I'm trying to see the scoreboard. So we have AS leading, followed by Robot, and then Ian. I think that's all for the Kahoot. Thank you very much for participating. Is there anyone that has a question? And oh, sorry, before that, the winners, AK, would you like to say something? Your victory speech? Anything? You're free to unmute. Okay. He says, thank you for the informative session. So, John, thank you very much. Yes. Okay, so does anyone have any question or anything to say? Okay, then I think we're done. Thank you very much, John. And it was a lovely session. Have a lovely day. And yeah, that's it.